Hi, good night, everyone. I am Sherry Sargent, and tonight we'll be doing part two of neuroanesthesia and an introduction to intraoperative neurophysiological monitoring. In this tutorial, we will discuss the basic principles of the most commonly used intraoperative neurophysiological monitoring modalities, the factors that affect intraoperative monitoring signals, and the clinical approaches on how to address these signal changes. Intraoperative neurophysiological monitoring is evolving towards a standard of care to minimize the risk of injury to neural pathways during neurosurgical procedures. Its importance lies not only in diagnosing injury, but also in creating a window of opportunity to salvage neural tissues at risk before damage becomes irreversible. To maximize its value, it is essential for the operative team to have a basic understanding of the principles of neuromonitoring and for the anesthetist to understand how it can be affected by anesthesia. Numerous modalities exist in the intraoperative monitoring armamentarium, and they can be classified into two types. Firstly, the detection of spontaneous activity, such as electroencephalography or EEG and electromyography, EMG. And secondly, measurements of evoked electrical responses of a specific neural pathway after an active stimulation. For example, SSEPs, MEPs, and brainstem auditory evoked potentials, BAEPs. These modalities can be used in isolation or in combination depending on the structures that are at risk during the surgery. So intraoperative monitoring can be useful in the perioperative period for patients at high risk of developing neurological complications, and the mechanisms of injury include direct mechanical disruption from surgical maneuvers, thermal injury from surgical coagulation, pressure injury from patient positioning, and ischemia due to local or global hypoperfusion. The ideal characteristics of a good intraoperative monitoring modality is that it is highly sensitive and specific, so that is a low false negative and false positive rates. There's fast response time, so responsive to changes in patient condition, the ability to detect tissue injury early enough to allow therapeutic interventions and to take place before irreversible damage occurs, and to help to clarify physiological targets and provide prognostication to guide subsequent care. The ischemic tolerance varies widely between individuals due to anatomical and physiological variations in vascular collateral anomalies, dominance, neurovascular autoregulation, and reserve. For example, it can be seen amongst patients who exhibit variable shunt dependency during carotid endarterectomies, or the nature of the surgery may expose the patients to different degrees of direct neuronal injury or vascular compromise, or systemic factors such as anemia, hypotension, and hypoxia can contribute to secondary injuries. False negatives reflects a genuine failure of the intraoperative monitoring, and this leads to unnoticed neural damages and devastating consequences. False positive results could trigger unnecessary intervention that may carry their own risks. So in the early days of its development, intraoperative neurophysiological monitoring was occasionally performed by the anesthetist, and it is now more commonly done by a dedicated neurophysiologist who, together with the anesthetist, surgeons, and the operative staff, form a multidisciplinary intraoperative team. Success of intraoperative monitoring relies on close collaboration within the team to form a clear common understanding of the location, nature, and timing of possible neurological injury, so that suitable monitoring modalities can be chosen. To minimization of anesthetic and technical interference on signal attainment, early recognition and interpretation of intraoperative signal change, clear communication of intraoperative monitoring signal changes to the intraoperative team and timely and coordinated multidisciplinary team response to signal change. So this table shows us the commonly used intraoperative monitoring modalities and the type of surgeries that they would be used for. For example, in intracranial or vascular surgeries involving cortical or subcortical pathways or their blood supplies, for example, with resection of intracranial tumors or AVMs, or vascular surgeries involving the carotid system, SSEPs and MEPs can be used. For surgeries at the posterior fossa or CP angle or brainstem, the brainstem auditory evoked potentials can be used, and surgery with risk of direct injury to spinal cord or roots or the risk of compromising their blood supply, for example, in tumor resections of the spinal cord, spinal deformity, or spine trauma surgeries, or other decompressions. We can use EMG for those, and surgeries close to cranial nerves or peripheral nerves, such as with the parotid surgery, thyroid, or surgical resection of vestibular schwannomas, EMG can be used. So to go into it, evoked potentials. In evoked potential monitoring, the neural pathway is interrogated by applying electrical stimulation at one end of the pathway, with the response being measured at the other end in the form of a potential difference, and this is measured in volts. Evoked responses are expected to come in within a certain time, and this is known as latency, from the stimulation and exhibit a certain strength, which is known as the amplitude and pattern, as we could see in Figure 1. These features are important in describing the evoked response, and any major decrease in amplitude, increase in latency, or a change in pattern suggests possible neural tissue compromise. So in Figure 1, it shows the examples of an evoked response with latency measured in seconds and amplitude measured in volts, and are important parameters when we describe evoked potentials. Somatosensory evoked potentials, or SSEP, is one of the most commonly performed modalities, and it monitors the ascending sensory pathways through transcutaneous electrical stimulation of a peripheral nerve. The electric signal travels to the dorsal nerve roots after stimulation, and it ascends the spinal cord via the dorsal columns. It synapses at the cervicomedullary junction, and it decussates ascending to the thalamus and finally the sensory cortex, as we could see in Figure 2. The upper limb SSEPs are usually generated from the median or ulnar nerve stimulation at the wrist, while lower limb SSEPs are from the posterior tibial nerve stimulation at the ankle or popliteal fossa. The resultant signals will be recorded at several stations along the pathway and average across multiple stimulations. Standard electrode locations include Erb's point, or the popliteal fossa for in peripheral SSEPs, in subcortical SSEPs, the cervical spine, and in cortical SSEPs, the somatosensory cortex. It can be performed continuously throughout the procedure and give a close to real-time monitoring of the sensory pathway. So in Figure 3, we see the placement of the SSEP electrodes for the upper limb with the median nerve at the wrist, which is circled in red, and the resultant waveforms. The nomenclature that is used for the peaks and valleys of the SSEP waveforms uses N and P respectively to designate the polarity of the recorded signal. Negative is usually up wave and the positive is downward, and an integer to denote the nominal post-stimulus latency of the signal in normal adults. The prominent cortical SSEP signal for the upper limb is N20 with an upward deflection at around 20 milliseconds, and for lower limb is the N45 peak. So SSEPs has long been used to monitor dorsal column function and its integrity during scoliosis surgery, and it is increasingly used in major spine and aortic surgery when the chance of spinal cord injury is significant. It has an additional advantage for detecting malposition of the upper limb causing brachial plexus injury, which can manifest as a loss of across Erb's point. It is also a more commonly chosen modality for monitoring MCA and ECA perfusion, artery perfusion during carotid endarterectomies and neurosurgical procedures. Moving on to motor-evoked potentials, or MEPs, this is used to monitor the integrity of the descending corticospinal and corticobulbar tracts, and it starts with stimulation at the motor cortex, and the electrical activity descends along the motor tracts and synapses onto the anterior horn of the spinal cord or cranial nerve nuclei. It then travels along a peripheral or cranial nerve across the neuromuscular junction to produce muscle contraction. So in figure 4, we see the motor pathway monitored by MEPs with the waveform recorded from the cord level with the D and I waves, which I would go into a little more later on, and the muscle level. Stimulation of the motor cortex generates evoked potentials that propagate through the brain and spinal cord to cause a muscle contraction. The response typically is recorded near the muscle as a compound muscle action potential, or CMAP, and the response can also be recorded over the spinal column as a D wave followed by a series of I waves, which are high frequency repetitive discharges from the corticospinal fibers. At the spinal cord level, most motor fibers reside in the lateral corticospinal tract, and this is seen in the red pathway on the diagram, and after decussation at the brainstem level. The anterior corticospinal tract is seen in the green on the diagram, and it contains fewer motor tracts. MEPs can be elicited either by transcranial electrical stimulation through the scalp or direct electrical stimulation on the brain. TES is used for functional motor monitoring of the motor system, while DES provides a higher spatial resolution of the motor cortex and subcortical tracts and is used for intraoperative motor mapping. At the spinal level, evoked responses can be measured in the epidural or intrathecal spaces as the D or direct waves, or I the indirect waves. D waves are negative peaks that are assumed to be elicited from direct corticospinal fiber activations, with the subsequent peak termed as I waves. Compound muscle action potentials at the effector muscles are more commonly measured because of their sensitivity, specificity, and minimal invasiveness. These are the composite electrical activities within the effector muscles, resulting from synchronous activation of the corresponding motor neurons within a nerve bundle. Recording electrodes are usually placed at selected muscles innervated by brain regions, nerve roots, or cranial nerves that are deemed at risk. Commonly monitored sites in the extremities would include the thenar muscles, the tibialis anterior, and the adductor hallucis. One disadvantage of MEPs is that they are performed only at intervals throughout the procedure and therefore pose a potential risk for delayed detection of neural injury. Motor deficits are significant morbidity after surgery, and MEP can be used if the monitor pathways is at risk. Motor neurons have a high metabolic demand, and at the spinal level, they are nourished by a single anterior spinal artery with variable reinforcement from the spinomedullary arteries. MEPs is used in major spine and intracranial surgeries to detect mechanical or ischemic injury, along the tract or at the end of the motor nerve. It is only used in conjunction with SSCPs for spinal cord monitoring, as together they grossly cover the spinal cord anterior-posteriorly. It also has a role in aortic surgery, in which the anterior spinal circulation may be compromised due to the spinal medullary artery insufficiencies, for example, occlusion of the artery of Adamkiewicz. Moving on to brainstem evoked potentials, BAEPs, is used to monitor the vestibulocochlear nerve, which is cranial nerve 8, and brainstem function. Acoustic stimulus is delivered by a device at the ear canal, and electrical signals generated by the cochlea travel along the vestibulocochlear nerve into the nucleus and various brainstem structures. The response is recorded by an electrode placed at the mastoid or earlobe. BAEP is used during posterior fossa surgeries, example excision of vestibular schwannomas or microvascular decompression for hemifacial spasm or trigeminal neuralgia, to assess brainstem and hearing function, which can be compromised as a result of cerebellar retraction, vascular injury, for example, injury to the posterior inferior cerebellar artery, or direct mechanical or thermal injury to the vestibulocochlear nerve and the brainstem. Electromyography or intraoperative EMG monitors monitor cranial nerves, spinal or peripheral nerves at risk by looking at either spontaneous or evoked CMEPs of the corresponding effector muscles. Spontaneous EMG records free-running electrical activities from muscles, which is normally of low frequency and amplitude. When the nerve is stretched or irritated, high-frequency neurotonic discharges will be produced, which alerts the surgical team or potential motor nerve damage, as we could see in Figure 5. The absence of such discharges, that is a negative response, suggests either an intact nerve or total denervation disrupting all nerve conduction. So the top two tracings in the picture, it shows the normal spontaneous EMG activity in the patient under general anesthesia, and in the bottom tracing, there's neurotonic discharge during nerve irritation. Triggered EMG, on the other hand, is produced by direct or intentional stimulation of peripheral or cranial nerves, with the resultant CMEP recorded from the corresponding innervated muscles. And we could see in table 3, so cranial nerves 3, 4, and 6, they would innervate the extraocular muscles. 5, the masseter and temporalis. 7, the orbicularis oculi, orbicularis oris, and mentalis or frontalis. 9, the stylopharyngeus. 10, the pharyngeal and laryngeal muscles. 11, the sternocleidomastoid and trapezius, and cranial nerve 12, the tongue. A positive CMEP from an appropriately applied stimulation will help to identify nerve structures when visual differentiation is difficult. This, for example, due to tumor invasion, and to confirm integrity of the nerve distal to the stimulation. A common application of triggered EMG is facial nerve mapping and monitoring during vestibular schwannomas or parotid tumor resection. So there are special anesthetic considerations with intraoperative neurophysiological monitoring. Many anesthetic agents produce a dose-dependent suppression of evoked potentials, making it essential to choose a regime compatible with a proposed intraoperative monitoring modality. Anesthetists should provide a stable physiological and anesthetic mode to facilitate meaningful interpretation of signal changes and accurate surgical guidance. When true signal change is confirmed, the anesthetist should be aware of potential non-surgical causes of neural injury and can be ready to act promptly to ameliorate further insults and secondary injuries. Using intraoperative monitoring may pose risks to the patient, and anesthetists should exercise appropriate precautions. So, most anesthetic agents alter the neural function by producing dose-dependent depression in these synaptic activities. In general, inhalational agents have greater effect on the evoked potentials than intravenous anesthetic agents, as we could see in Table 4, and the choice and dose of the hypnotic agent should be tailored to the modalities used. Going in specifically to the volatile agents, inhalational agents cause a dose-dependent decrease in amplitude and increase in latency of evoked potential responses. For SSCPs, such effects are more pronounced on cortical responses than on subcortical or peripheral responses. Adequate SSCPs can usually be recorded at a MAC or minimum alveolar concentration less than 1. However, for patients with baseline neurological impairments or neuropathy from systemic disease, lower levels of inhalational agents may abolish potentials and make monitoring impossible. MEP is affected by even lower concentration of volatile agents as they suppress lower motor neuron excitability more profoundly, and BAEPs and EMGs are resistant to the inhalational agents. With regards to intravenous agents, SSCP signals are unaffected by high barbiturate doses, whereas MEP signals are sensitive to barbiturates. Benzodiazepines used at premedication doses would not suppress SSCPs and MEPs, whereas ketamine can enhance SSCPs and MEP responses, which may be beneficial for monitoring when used to supplement anesthesia or analgesia. Etomidate can augment the amplitude of cortical SSCP recordings without affecting the peripheral evoked potentials or subcortical responses. And with regards to propofol, it is known for its favorable pharmacokinetic profile and titratability. So propofol suppresses SSCPs and MEPs in a dose-dependent manner, but to a much smaller extent, allowing adequate measurements at commonly used clinical doses. It is considered the anesthetic agent of choice to facilitate intraoperative monitoring, especially when MEP monitoring is used. And all anesthetic agents take time to equilibrate after dose adjustment. Therefore, it is undesirable to alter the dose unnecessarily during critical steps of surgery, as they may confound the interpretation of the intraoperative monitoring signals. With regards to opioids, evoked potentials can be recorded even at very high doses of opioids. So infusions of short-acting potent opioids such as remifentanil are commonly used to reduce anesthetic requirements during surgical procedures involving evoked potential monitoring. With regards to muscle relaxants, MEPs and EMG monitoring are affected by muscle relaxants, which inhibit electrical activity across the neuromuscular junction, affecting signal recording as muscle contraction can no longer be generated upon neural stimulation. If MEPs or EMGs recording is necessarily shortly after endotracheal intubation, one can administer a cautious dose of a short-acting muscle relaxant before laryngoscopy and allow its effect to wear off before monitoring commences. And if necessary, reversal agents can also be given prior to monitoring. Intubation without neuromuscular blockers is possible with adequate depth of anesthesia from propofol and remifentanil infusions. Occasionally, a mild degree of neuromuscular blockade is desirable in some surgeries that also monitor MEP or EMG. For instance, in paraspinal muscle relaxation, often facilitates the initial dissection during scoliosis corrective surgery. If a muscle relaxant has to be used intraoperatively when monitoring MEPs or EMGs, the level of paralysis should be carefully controlled and monitored, ideally guided by a nerve stimulator with an accelerometer rather than visual inspection. Neuromuscular blockade should be maintained at a stable and mild level throughout the monitoring period, with a neuromuscular blocker infusion aiming for not more than 2 twitches on 3 or 4 stimulation. With current anesthetic techniques, such as TIVA, with propofol and remifentanil infusion, it is possible to avoid the use of neuromuscular blockers, although in most cases providing an anesthetic environment for more reliable MEP and EMG recording. So just summarizes the anesthesia issues relating to intraoperative monitoring. Physiological parameters, inadequate oxygen supply to meet the metabolic demand of neural tissues is the main cause of pathological signal change seen in the evoked potentials. That is, an increase in latency or a decrease in amplitude. Oxygen supply to the brain is dependent on adequate blood flow, content, and cerebral perfusion, which is in turn is affected by systemic blood pressure and caliber of the intracranial vessels. Reducing systemic or regional blood pressure can depress cortical evoked potential monitoring, and SSEP and MEP latency increases and amplitude drops associated with a reduction in cerebral blood flow and possible embolic events. Patients with baseline abnormal cerebral or spinal perfusion or impaired autoregulation are at a higher risk of ischemia with fluctuations of blood flow. Hyperventilation and the resultant hypocapnia can constrict cerebral vasculature and diminish oxygen delivery. The effect is more significant in patients with compromised vascular anatomy and when compensatory autoregulation is already maximized. With regards to anemia and hypoxia, it reduces the oxygen content in blood, and latency of evoked potential starts to increase and amplitude decreases when the hematocrit falls to 10% to 15%. Intraoperative monitoring signals change may occur at a higher hematocrit level if there's concurrent hypoperfusion. Hypothermia decreases the central and peripheral nerve conduction velocities, hence increases the SSEP latency. Therefore, the core temperature should be maintained within 2 degrees of baseline. Regional hypothermia, for example, by exposing the spinal cord or CP angle to cold irrigation, can affect evoked potential monitoring. And limb cooling, example from cold infusion of fluids, may increase SSEP simulation threshold in that extremity and alter the degree of peripheral nerve stimulation. So patient positioning as well is very important. For surgery, it can cause vascular or neurological compromise leading to signal changes. For example, in the lateral position, the position can cause direct brachial plexus compression or vascular insufficiency of the dependent arm. Neck flexion as well for spinal or posterior fossa surgery may cause mechanical pressure on the cord, nerves, or important vasculatures, especially if the structures are already predisposed because of underlying pathologies. In patients with high risk of positional neural injury, it may be desirable to measure evoked potentials before and after patient positioning. If the potential diminish after adopting the operating position, patient posture should be readjusted before surgery begins. It is also important to note that positional neural injury can lead to signal changes gradually and insidiously. Hence, it should remain as a differential diagnosis of intraoperative signal change. So moving on to the complications with intraoperative monitoring and precautions. During MEP stimulation, muscles for mastication are activated and can result in bite injury if bite blocks are not meticulously placed. Any patient's movements can be deleterious if it occurs during a critical stage of surgery, for example, application of clips during aneurysm surgery. Hence, good communication between the anesthetist, surgeons, and the neurophysiologist is imperative. Both SSEP and MEP stimulations will result in patient movement, especially when the stimulation current is high. And if the patient moves vigorously during MEP acquisition, the anesthetist should inform the neurophysiologist to check if a lower stimulating current can be used. During SSEP acquisition in an unparalyzed patient, distal limb movements can also affect blood pressure or pulse oximetry measurements if the arterial line or pulse oximeter is on the same extremity. So subdermal needle electrodes may be placed in close proximity to vascular access, as we could see in figure 6, and even the ET tubes, for example, during cranial nerve monitoring. So communication with the neurophysiologist is desirable when sitting and readjusting these electrodes intraoperatively. Local guidelines on safe handling and disposal of sharp should also be followed, as the corkscrew and subdermal needle electrodes may be contaminated with the patient's blood. And on removal of electrodes, the site should be compressed until hemostasis is achieved. So how do we manage the intraoperative signal changes? It is important that an optimal and stable physiological and anesthesia milieu is present during the acquisition of a baseline reading, as it will be referenced for the rest of the procedure. Different critical criteria of what would constitute a significant signal change exists, in part because of the variations in study protocols, anesthetic regimen, and neuromonitoring setup. A true sudden loss of signal should always prompt remedial interventions, while a 50% reduction in amplitude and a 10% increase in latency for evoke potentials are considered significant and should be communicated to the whole operating team such that the cause can be identified and treatment promptly to prevent further damage to neural tissues. When a significant signal change is detected, the persistence of this change should be confirmed and technical issues or false positives should be excluded. This can involve rerunning the evoke potentials, ensuring both the recording and stimulation parameters are correct, or cross-checking with other modalities for associated changes. The management varies depending on the likely cause, and the list of differential diagnoses for signal change can be narrowed down by considering the pattern of change, the location of the tract at which the signal drops occurs, and the laterality of the change. So this here is a checklist for multidisciplinary response to neuromonitoring changes during surgery. So when signal changes are identified, we could pause the surgery and announce the signal change, summon the senior attending for anesthesia and neurosurgeons from the neurophysiologist or the intraoperative monitoring provider. They can repeat trials of intraoperative monitoring tests, check the electrodes and connections to troubleshoot, confirm impedance of the stimulation and recording electrodes, optimize stimulating parameters, and setting of the intraoperative monitoring machine. Rule out artifact or noise, and also to assess the patterns and timing of changes to see if it's focal or asymmetrical or symmetric changes. From the anesthetic point of view, ensure no inadvertent administration of drugs that can accurately affect evoked potentials, to check extent of neuromuscular blockade and paralysis, to check the neck and extremity position, especially if there's a unilateral signal loss, and to optimize the maps and optimize the hematocrit. Aim at a hematocrit greater than 30%, optimize pH and PCO2s, and maintain normothermia and normoglycemia. From the neurosurgical aspect, evaluate any maneuver, example, surgical retraction, just prior to the intraoperative monitoring alert. Consider suspending the surgical procedure and observe any recovery of intraoperative signals. Irrigate the surgical site with warm saline or papaverine and arrange perioperative imaging for further assessment as needed. Some of the ongoing considerations is to wake up the patient and to reassess, consider neuroprotection strategies, for example, for spinal surgery, intravenous methylprednisolone protocol, and for intracranial surgery, pharmacological burst suppression, quantify any signal recovery after interventions, and consider surgical alternatives or bailout plans, reevaluate perioperative hemodynamic targets based on the intraoperative monitoring signal responses to salvage measures. So in conclusion, intraoperative neurophysiological monitoring, it offers an attractive option for real-time monitoring of the nervous system, but successful implementation must be built on a team approach to facilitate intraoperative monitoring and appropriate corrective measures when major signal changes happen. The anesthetist plays an important role in evaluating the impact of anesthesia and physiology on the intraoperative monitor signals and optimizing these factors intraoperatively. There is growing evidence that intraoperative monitoring reduces neurological disability from surgery, but a universal protocol and guideline for its use and interpretation is still lacking. This is in part due to variations in patients' premorbid neurological status, the type of anesthesia, and the setup of neuromonitoring, and the nature and approach of surgery. Each institution may develop its own protocol on what and how to monitor and what degree of signal alteration amounts to a significant change, criteria making communication amongst the intraoperative personnel vital. So this brings me to the end of part 2. These are my references. Thank you, everyone.